The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridge Ed in their entirety. This is the FlightBridge Ed podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hello, everyone, and welcome to the FlightBridge Ed MDCast. I'm your host. My name is Mike Lauria. I'm an emergency medicine, ICU, critical care, and flight transport physician at the University of New Mexico and the medical director for FlightBridge Ed. Today, we're continuing our series on OB critical care. So obstetric critical care is a topic that's definitely near and dear to my heart, and especially nowadays as we've had some issues with taking care of these critically ill patients, especially in transport. This is a continuation of the series, and this is episode 4, and today we're going to be talking about disseminated intravascular coagulation, or DIC. So as we've kind of started out the past couple of podcasts, I just wanted to harp on the fact that I think this is really important because maternal mortality rates have been on the rise in the United States for the past several decades. In fact, we've slipped to 65th in terms of OB mortality, risen to now about 17.4, from 17.4 to about 32.9 deaths per 100,000. In comparison, some of the countries that are doing really well at this will report rates as low as like 1 or 2 or 3 deaths per 100,000. So 65th in the world, not doing so great in this area. And it's particularly important for us in the transport world because as many smaller hospitals and rural hospitals either don't have obstetric capabilities or care or are closing their OB units, we're seeing sicker and sicker patients being transported to larger tertiary and quaternary care centers. In fact, about 19% of maternal and peripartum care takes place at facilities that don't deliver a whole lot of babies at all. So many places will be transporting their patients to larger institutions, and they will be calling you guys. So tell me with this series, I am very excited and proud to introduce a friend of mine and one of our assistant medical directors at Lifeguard, Dr. Elizabeth Garcher. She's an obstetrician and MFM specialist here in Albuquerque, and also, and very uniquely, flies with us on a regular basis, so understands our environment, which is fantastic. Very few OBGYNs and certainly very few MFMs can say that. So welcome, Dr. Garcher. Welcome, Liz.
Thank you. I appreciate it.
Before we get started on the clinical topic, so just so you know, Dr. Garcher and I have no conflicts of interest. And remember that we are going to be discussing the evidence around some of these things, guidelines, recommendations in our practice. But always remember that what we're going to talk about here on the podcast is not a substitute for your local protocols, guidelines, regulations, or laws in your state. So always make sure you pay attention to that stuff first. So let's start out with it. Let's get into the meat and potatoes talking about DIC. So how do we even define DIC? Well, DIC is defined by the International Society on Thrombosis and Hemostasis as, quote, an acquired syndrome characterized by the intravascular activation of coagulation with a loss of localization arising from a number of different causes. It can originate from and cause damage to the microvasculature, which, if sufficiently severe, can produce organ dysfunction. So that's kind of like a long-winded way of saying that there are essentially three things, and this definition emphasizes three things. First of all, that this disseminated or all over the place coagulation is, number one, secondary to something else. There is something that causes it, and as we'll talk about later, probably one of the most important things is tracking down and finding that cause. Two, it's diffuse, uncontrolled systemic coagulation dysregulation. So it's lots of little clots, and sometimes actually relatively large clots, all over the place where there really shouldn't be. And 3, it demonstrates marked endothelial dysfunction and damage throughout the microvascular beds. And this is manifest both by worsening coagulation and also changes in vascular tone, which can cause problems such as hypotension. So all those 3 things are pretty much key. It's caused something else, it's coagulation all over the place that's completely out of control, and it causes significant damage to the vessel beds, which can result in end organ damage, hypoperfusion, and global hypotension. Now, I will say it's pretty rare. Overall, in pregnancy, in pregnant patients, it occurs about 0.03 to 0.35% of pregnancies, which overall it sounds like that percentage is pretty small, but when you imagine there are very many young, healthy females that become pregnant, or sometimes not so healthy females that become pregnant and have other complications such as postpartum hemorrhages and other clinical issues, it is not completely insignificant. So small, but not necessarily insignificant, and has a very high mortality and morbidity and can be a very, very challenging clinical situation. So even though it's rare, it is very, very, very dangerous and a severe condition. So that's sort of what it is, and we've gone over that. It's relatively rare, but how do we actually diagnose it? How do you recognize it? So, Liz, what are some of the diagnostic criteria, either lab tests or clinical findings, that crews should look for and say, aha, this is DIC?
Yeah, definitely. So it's something that's not subtle, that's for sure. So it's often met primarily with some clinical signs. So things that you're going to be seeing are sort of bleeding from everywhere. So bleeding from the gums, from actual places where you put in the IV, so venipuncture sites, incision sites, mucous membranes. So we have like post C-section patients that just begin oozing from every orifice. And that's sort of like one of the biggest qualitative signs that you can see. You can also have this in other settings besides, obviously, after surgery. So you can also have non-focal vaginal bleeding, which in my experience is like almost watery even after delivery. It's very, very thin appearing and is associated with shock in those situations. So it can be also in women before delivery, during delivery, or after in even a vaginal delivery. And the other thing you'll see is petechia or purpuric rash with that, because you'll see that you're having this clotting and bleeding throughout the body. And so you'll see that this is becoming sort of like a rash throughout their body as well. You can have, however, slightly more insidious DIC as well. So you can have it where it's not all of a sudden everything is bleeding everywhere. And that can be more diagnosed with subtle lab findings, things like an acute kidney injury or transaminitis instead. But this is something that I would say hang your hat on the overt signs that you're seeing, and that's what's going to be something you need to address in any transport situation. But it's not that there's not more subtle, non-overt things that you can find that you happen to be called about a patient that seems stable and then come and find that she has low fibrinogen, low platelets, low hemoglobin, and that's concerning for that more insidious DIC, even if she looked stable at the time originally. Other lab things besides the fibrinogen, platelets, and hemoglobin can include having a prolonged PT, PTT, and of course an elevated INR in that situation. D-dimer can be hard because pregnancy alone makes it really elevated, but this will also go along with that of having a high D-dimer in a situation of having DIC. And then you can see other signs of hemolysis in general on lab findings, things like a low haptoglobin, a high LDH, a high bilirubin, and a high plasma-free hemoglobin. And you get, the shock and hypotension, so you get release of vasoactive substances from intravascular coagulation. And so you can see that as well, and then subsequently have that shock and hypotension even rapidly. So overall, with it mostly not being a very subtle thing, it's not necessarily one that we need to quantify scores, but there are ones that can be used. to quantify scores in pregnancy, even for risk of DIC, and that can be found more in like a learning, I guess I would say like a academic setting and for academic curiosity, but it's not something I've ever really used at the bedside. But keep in mind that these lab findings can be a really late sign of disease progression. So looking at clinical evidence is the most important aspect and is the thing that's going to clue you in that we need to be acting fast and we need to be working on fixing this underlying condition specifically. So PT and PTT, for example, really don't prolong until your clotting factors are already depleted by more than 50%. So you're already in a lot of trouble by the time you're going to see that as a cause or something that you're going to see on their lab findings.
Yeah, I always thought that was pretty wild because in a lot of the critical care transport textbooks and a lot of other textbooks in general, even in medical school, they always talk about some of these signs like a fibrinogen less than 100 and a PT and a PTT here, or that are X prolongated by X. But really wild by that point, you're depleted by more than 50%. And I think in both of our experiences in both pregnant and not pregnant patients, that by that point, things have escalated clinically and are spinning out of control. Because when that whole cascade is activated that quickly and that diffusely, you really, really need to act quick. And I think that, keeping that in mind, that those are prolonging, is certainly a late warning sign, but absolutely acting on your clinical suspicion and all of the other findings taken as a whole is just super, super important in this patient population. Now, getting down to the pathophysiology of what's really going on here, well, I think whenever I talk to experts on both the transfusion medicine world, and the critical care world, and the OB world, I don't think that anyone knows exactly what's going on. And in fact, the precise pathophysiology, many experts will agree that it remains only partially elucidated and is still pretty complex. In the setting of significant hemorrhage, various authors have suggested that it's really in perhaps a confluence of multiple things that come together that trigger this diffuse consumptive coagulopathy where you're throwing clots in all sorts of little vessels all over the place and just chewing up all those clotting factors. In fact, one hypothesis is that hypoperfusion and local tissue hypoxia from internal hemorrhage, for example, can result in the expression of tissue factor or external hemorrhage, as it would be in some cases. So we've had a couple patients that I can think of, one in particular, who had a very, very bad postpartum hemorrhage, which we discussed in a previous episode. And so it never really made sense to me how hemorrhaging someplace could trigger clotting all over the place until I went through and read some of these papers where it discussed it. But then it kind of makes sense because the expression of tissue factor is a potent trigger of the clotting cascade. And this in and of itself could potentially cause this profound dysregulation, excess thrombin generation, platelet activation, or defective or suppressed anticoagulant factors. So things like tissue factor inhibitor, antithrombin, protein C, suppressing these actively with this generation of tissue factor, as well as this paradoxical exaggerated hyperfibrinolysis sometimes and activation of other inflammatory mediators. And so the progression of this is essentially the activation through the extrinsic clotting cascade of tissue factor going through the common pathway, forming thrombin, eventually fibrin, and then plasmin, breaking down the fibrin into fibrin split products. And this was sort of another really fascinating, really interesting piece when this was explained to me, that sort of brought everything together and helped me understand this process so well. And this was actually presented by Dr. Michael Foley, who is very well known in the MFM world and teaches a phenomenal course, which I'll give a quick plug on later. And the way he explained it was essentially that these fibrin split products are really the bad players, as he referred to them. They're like these tiny razor sharp fibrin fragments like little pieces of metal or little razor blades that go flying through the bloodstream. And what they do is a number of things. If you think about what they actually do, it kind of explains a lot of the manifestations that we see. So, for example, these sharp little fragments of fibrin damaging platelets or causing platelet dysfunction as they get stuck to different platelets, damaging other fibrin strands, so actually coming through and slicing up other forming pieces or forming threads or molecules of fibrin. And also, we've mentioned that endothelial damage was a huge part of this. So imagine those sharp little fibrin fragments flying through and getting caught in some of the smaller blood vessels and tearing up or damaging the endothelial lining, which can cause things like vascular leakage or vasodilation or further endothelial injury that makes clotting more likely in some of those areas. They can also damage RBCs and cause hemolysis, like we see in various intravascular hemolytic processes. Thrombi can cause organ injury, so they can get lodged places in some larger arterioles and vessels that feed some of the key organs in your body, like your liver and your kidney, which can cause elevated liver enzymes and almost like a ischemic hepatopathy, as well as an acute kidney injury if they block off or damage some of the microvasculature that's going into your kidneys. And finally, that bradykinin that's produced from activated clotting factors, like, for example, factor 7, this is actually a pretty potent vasoactive peptide that prevents smooth muscle from contracting, causing vasoplegia, low blood pressure, hypotension. So that was another thing that I never really got, like how clotting can cause a patient to suddenly become profoundly hypotensive. And if you think about it, like if you have all these little clots forming everywhere, this dysregulated clotting everywhere in the body, that's a tremendous amount of bradykinin being produced very quickly in relatively short order. So when you understand that part of the clotting cascade and this pathophysiology, it all kind of makes sense about what's going on with these patients. So let's think about, well, what actually causes it? How do you end up in this situation? So Liz, would you mind going through with us, both statistically and then in your practice, what are some of the things that cause DIC?
DIC is one of those things that, like Mike has said, it really follows bleeding a lot. So the number one cause, and definitely what I've seen most commonly, is abruption. So abruption of the placenta in situations like a car accident, which would be sort of what people think of classically, but also just after a fetus has demised. So things like if they had high blood pressure that led to the placenta abrupting off, then you still have also all of that blood coming into mom, and you have internal bleeding after this demise of the fetus. And so also with that demise can increase that risk. But really the number one cause, abruption. And so that's been reported in about 36 or so percent, about 37% of cases. And then number two is that classic bleeding, postpartum hemorrhage. And that's about 29-30% of cases as well. And so that is the top, that's already 60% of the time is from bleeding, be it in the uterus or on the floor after a hemorrhage in the setting of delivery. And then the third is severe preeclampsia or HELP syndrome. And HELP stands for hemolysis, elevated liver enzymes, and low platelets. So it's a pretty self-explanatory diagnosis. If you talk to some people, they say that's on the spectrum of severe preeclampsia. But really, the bottom line is that you have to have the low platelets specifically and elevated liver enzymes. And so those two things can be seen in preeclampsia, but they may not be. And so some people will say people had severe preeclampsia and then went into HELP syndrome, or they'll just present straight up right away with all of those symptoms. So it really depends. But that's why they're kind of clumped together. And those make up a much smaller proportion. Although I'd argue as our population continues to age, the average age of first birth continues to rise in the U.S., we're going to see a lot more people that have a lot of risk factors for hypertension and therefore, in turn, a lot of risk for preeclampsia. So it's one of the things we see most commonly here in New Mexico, but is something that is lower on the list in the setting of this DIC. There's also more rare causes, of course, and that includes things like sepsis, acute fatty liver of pregnancy, which itself kills people rapidly, an amniotic fluid embolism, ARDS, or retained fetal tissue, and that kind of goes along with demise of fetuses. So things like that, other causes that aren't the top three, but can be seen in pregnancy rarely.
Gotcha. So now we kind of have an overview of some of the things that can trigger it or cause it. Your approach and how you would recommend, so crews show up at the bedside with this patient that has some triggering factor. What would you recommend that crews look for? What's your general approach to managing it?
Yeah, so the number one treatment is fix the problem. So what is causing it? If you have an abruption of the placenta, delivering that baby, even in the setting of the baby having demise, it's really important that you remove that source of that continued bleeding, or treating the postpartum hemorrhage, be it with medications or with surgical treatment before you're leaving, if it's that severe. And then checking blood pressure, see where you're at in that regard, and make sure that you're not missing severe preeclampsia, which you make sure to load with MAG and those kind of things beforehand. So really, the most important 1, 2, 3 is fix the underlying issue. So fix what you can treat before you're going, if at all possible. But on the other side, if, like, for example, you got called and you said they were a stable patient, and then you get there and there's a lot of symptoms that you're really concerned that this patient is either going into or on the brink of or in Florida DIC, make sure that you're contacting your friendly neighborhood maternal fetal medicine doc. I'm always happy to take a call at 2 a.m. about it, and I know that most of my colleagues are too, and that would be, the receiving MFM. It's really important that we come up with a plan together, because if we're going to have to be flying her, in New Mexico, we have long distance, sometimes a couple hours before we're getting her to the hospital. I want a really good complex plan of how we're going to manage these razors through her body. This causes that we can't treat before we get to my hospital. So it's super complex, really time sensitive. So let's all work together on that.
Yeah, absolutely. And I would really like to also emphasize Liz's point that, I have been doing this for more than a decade and a half at this point, through medical school, through residency, through fellowship, and I will still call under these circumstances to coordinate with some of our MFM colleagues at the receiving hospital to make sure that I'm not missing something, and to make sure that I'm on point. I would also say that if you heard, like Liz brought up a couple of really good points in there too, that managing the things that you can. If you can't, that's also important too, to understand that if it's an abruption or something that you need an obstetrician or a maternal fetal medicine specialist to perform a skill that you can't do, like deliver the fetus, then that should weigh into your math too, in terms of that might be the patient that you start moving quicker on and resuscitate as you go, so that you can get them to definitive care, almost like a trauma, as opposed to, if it is in fact a postpartum hemorrhage, that there are medical interventions that you can do, starting those medical interventions immediately and trying to perhaps stabilize them before you get going. So, and Liz touched on the key thing, which is managing the underlying condition. But now let's get into managing some of the coagulopathy, because this is a key thing, and this is absolutely something that our critical care transport crews can do, have the ability to administer blood products and some of these other things. So Liz, can you walk us through how you recommend managing the coagulopathy associated with DIC?
Yeah, definitely. One of the biggest things that people love to look to, I feel like, and I'm guilty of this as well, as the computer, right? Like, what are your lab results? And individual blood tests like PT, PTT, and particularly INR aren't going to be very helpful in this situation. So looking at something that's more of viscoelastic testing, like your ROTEM or your TAG, is going to be your way to go in that case. I, personally end up calling my anesthesiologist to help me interpret said things, but in general, that can be really helpful in treating your DIC in the moment, because it's a snapshot. It's something that's capturing where we're at this moment, instead of 30 minutes ago when we drew that blood. So that's definitely something to look. If you're going to look at the computer, make sure it counts. And then often you have smaller sending facilities, right? And these tests aren't going to even be available to you anyway. So they won't come back. Maybe your INR is a send out anyway, so that's not helping you. So don't rely on those tests to see if you're ahead of the game. Instead, let's activate our massive transfusion, and starting with 1-to-1-to-1 ratio right away before you have that information is something that is really important for these patients because we already have this massive bleeding and we need to get it under control. So just get transfusing. And for this population, we're going to target a MAP of greater than 65 and try to stop it, again, at the source. Getting back to what's causing this and trying to treat your underlying cause is going to be the biggest bang for your buck as you get transfusing at the same time. In experience dealing with DIC, especially in the middle of nowhere, it can be really hard to do a perfect 1-to-1-to-1 ratio because finding platelets in the boonies or anywhere where you're not able to massage them at room temperature, it can be really difficult. And so we've done different things with that. We've brought a surgeon with us in order to try to do the surgery out there with the platelets in hand, or we're trying to do different things. So getting creative and, again, talking with the MFM to try to figure out what we can do to mimic that or get moving as fast as we can. And speaking of the different lab values, we talked about fibrinogen being really low. So replacing fibrinogen is also something that you want to target, and that's not going to be in FFP. It's going to be more commonly in cryo or some places, if you can afford stock, to carry fibrinogen concentrate and use that. That works great, of course, too. But cryo precipitate is going to be probably what you'll have on hand to help with the fibrinogen level. And if you're at an outside hospital, like I said, beginning transfusion, if you already have underlying addressed problems, do it and get where you need to go as fast as you can with an understanding of a plan in place that we are replacing what we can. We're doing everything we can for these patients. And then another thing to consider, especially in the setting of a postpartum hemorrhage, and something that I often forget that can be helpful at some situations, is TXA. But if they're already in DIC with evidence of the end organ damage, you're not going to be giving them a lot of benefit. That's more of a, when we recognize the hemorrhage before we called you, we should be trying to think about that as well. There's other things that are on the horizon, maybe more experimental treatments or medications because they're not super available, especially for transport, things like DDAVP, recombinant thrombomodulan, if I'm saying that correctly, probably not, and factor 7, things like that, recombinant factor 7. So it's just things that you probably won't necessarily have around, and they're questionable efficacy and not really used in this setting, but just had to mention them since we're talking about all the different aspects.
Yeah, absolutely. And I'll add a couple things there too. One, if you know that you're going out on a call for this, I would absolutely, if at all possible, see if you can bring extra blood. So like we, for example, don't bring a lot of blood products with us. Probably, I think at this point we'd have 2 units of PRBCs and 1 plasma, hopefully getting a little bit more in the future. That has been, quite frankly, insufficient in the past. I would encourage people, even if you are at a small outside facility, I think when patients, especially our OB patients, which are absolutely salvageable if we can provide really good, aggressive critical care and good support to them, this would be the case where I would ask the outside hospital for whatever they got. Help us out. Whatever you can give us that we can give to the patient now, that we can bring en route, because generally speaking, most aircraft and transport teams are relatively limited in what we can actually carry with us on the aircraft. The other thing which I'll note, which has been of use a couple of times, and this is again in conjunction with the MFM and OB team that will be receiving the patient. We often say, like for us as transport specialists, like some of the labs will take too long for us to, we're not going to sit at the bedside for like an hour or 2 while even the labs that are available at some of these outside places are in progress. But I have found it fruitful sometimes to actually check with the MFM team and see if they want any labs sent and ask ask the team at the outside hospital to send them and get the contact information of the outside hospital team. So that way, while you're packaging and moving, by the time you get to the outside hospital and they land in the ICU or they land in the OR or wherever, often those tests may be available. And under some conditions, that may be helpful for the team that's receiving the patient. So even though they may not be helpful for you, it's not unreasonable to discuss with both the receiving and sending physician if they would like some of those things to go in process now. So awesome. So I think that was an awesome review of the epidemiology and some of the pathophysiology. We talked about how to identify a DIC and how to manage it in general, and then specifically the coagulopathy. So I think in summary, some of the pearls that I think crews should take away from this podcast are, number one, DIC is absolutely a critical care condition. It is a life-threatening condition, and it is essentially this dysregulated clotting resulting in consumptive coagulopathy, i.e. there's the coagulopathy as a result of all of these clotting factors and substances being consumed rapidly throughout the body, and ultimately the inability to clot where it is actually needed. So, for example, in the uterus. There are quantitative scores and some lab tests, but really focus on a few critical things. One, understanding those high-risk conditions that will drive DIC, like abruption, postpartum hemorrhage, severe eclampsia, HELP, sepsis. When you see someone who's having clinical manifestations, such as evidence of thrombosis, that is the purpura or petechiae, or dangerous, uncontrollable, life-threatening bleeding, like way more thin vaginal bleeding than you would expect, or hemorrhaging from the various venipuncture sites or whatever, in the setting of having one of those conditions, you should have a very high clinical suspicion, and especially in the setting of shock and hypotension. With those three things, a potential driving factor or cause, the clinical manifestations on exam or what you're experiencing in shock and hypotension, I would begin treatment. I would absolutely begin treatment. Always remember, fix the underlying problem if possible. And that can be being expeditious in getting the patient out of there and to surgery as quickly as possible to treat the underlying problem with some of these things, and stabilizing them as much as possible, having a good second-line plan if necessary, and making sure that in various transport situations that we frequently encounter in more rural areas, that you have a robust plan with in particular the receiving team. And always remember that transfuse and replace clotting factors and attempt to restore normal coagulation. Yes, it may be very reasonable to give them packed red cells, but this is a disorder of coagulation. So think about giving them red cells, but also making sure that we're transfusing appropriately the FFP, fibrinogen, or cryo in some cases as well, and if possible, platelets. Although, as Liz pointed out, it's hard to get those platelets in the hospital these days, never mind during transport. So those are the key things to keep in mind. Before we wrap up here, I just wanted to give a shout out, as I had mentioned, some of one of the best talks on this topic in OB in any setting, DIC, was delivered by Dr. Michael Foley. He actually started and runs a phenomenal course. I'll give a shout out to it now. I have no conflict of interest with this course. I went to it myself. I paid my own money to go because I was so excited about it, and it did not disappoint. It's a course that's put on by Banner University Medical Center in conjunction with the Society for Maternal Fetal Medicine. It's called the Critical Care OB course, and it's run every year, actually, in November in Scottsdale, Arizona. And yeah, it's primarily designed for obstetricians and MFM providers, but it absolutely, totally, 1,000% applies to intensivists, emergency physicians, and critical care transport crews. If you're doing this kind of work, it is definitely not over your head. It is totally within our wheelhouse, and I would add that some of the simulations are fantastic. In fact, I learned a ton from going through the simulations with some of my obstetrician and MFM colleagues. and just by bouncing ideas off them and simulating running these resuscitations with them. So really, really fantastic. If you can, I'll put it in the show notes and absolutely take a look. Well, ladies and gentlemen, that's all for now. Thank you for joining us for this next episode of the MDCast on OB Critical Care on DIC, Disseminated Intravascular Coagulation.
This has been a production of the Flight Bridge Ed Podcast, leading the way in pre-hospital critical care and emergency medicine education.